Fundamentals of Massage, Chapter 15. Clinical Massage Techniques. Let's do this. Okay, we're going to talk about some neurophysiological therapies. So this would include something called neuromuscular therapy, which in short is NMT, muscle energy techniques, MET, and passive positioning therapies, or they also call those positional release techniques, PRT. Last but not least, we're throwing myofascial techniques down on this list. And you're like, what are these? We'll learn. So some of this should be review. We're going to talk about dysfunction of the body. So when there's dysfunction of the body, primarily we're talking about the musculoskeletal system. Dysfunction would be inflammation, ischemia, trigger points, muscle tension and weakness, and or nerve entrapment or nerve compression. When an area of the body is restricted by pain or limited by the range of motion, other areas of the body start to compensate. And this results in further dysfunction. So say you have terrible posture, you've been laying around on the couch we'll say, leaning to the left, okay? And this starts to become a habit because you have a week of staycation. So the areas on the left side of your body are going to be really, really shortened, maybe painful, into a cramp perhaps. In the right side of your body is going to be overstretched. Now, because you might have an injury, we'll say on the side that's being compressed, other muscles around it might start engaging to fix that alignment problem. Now, typically, it's not just going to happen. You're just going to be sore for like a staycation week. But if this is a continuous thing, your habit, your posture, it's going to result in further dysfunction with further muscles. So that's why I tell people sometimes where the pain is not the problem. A lot of times there's also referred pain coming with this. All right, neuromuscular therapy assessment. So when we're doing neuromuscular therapy, we're looking for abnormal signs within the body. The biggest one would be your postural or your biomechanical deviation. So things that aren't asymmetrical anymore. Also, nobody is perfectly asymmetrical. Everybody always has a little bit of a difference because we have dominant sides or injuries or postural issues. Other signs to look for that are abnormal would be congestion in the tissues. So as you guys learn to palpate a little bit better, you'll be able to tell between two sides when there's what we would call congestion and when there isn't. What I consider congestion is the tissue seems a little larger, warmer, more inflamed feeling. This will come with time. Contracted muscle or a taut fibrous band. So contracted muscle can come in the form of trigger points or knots that are literally like circular, or they can come in bands. So both of those are can be considered a trigger point or just a taut area. Taut means overly tight. Nodules or lumps. So this could be muscular, or this could also be like a tumor or a fatty cyst or something like that. Cysts can also affect the body. So anytime there's some kind of weird foreign objects, we'll call it, or tissue that's not supposed to be there, it's going to affect how the muscles and the ligaments and the structure around it glide. So sometimes that cyst can cause other trigger points or other issues. Does that make sense? Yeah. Trigger points. So trigger point, remember, is a taut area in the body that refers pain to another area. Restrictions between the skin and underlying tissues could be an abnormal sign. Also, variations in temperatures. A lot of times, if I have someone who comes in who is recovering from an injury or post-surgical, I'll just kind of rest my hand on the area and feel around to see if it's still radiating heat. If it is, I'm going to not work directly on the area, and we're going to work around it. Swelling and edema, and then also general tenderness are all abnormal signs. Healthy tissue doesn't hurt when being palpated, unless it's very deep pressure, but we're not doing that. Massage considerations. Neuromuscular therapy is not appropriate for acute soft tissue injuries in their initial healing stage. Remember, this stage can last 48 to 96 hours. Some people say 2 to 3 days. This is adding more time. For the first stage of healing, if they're in that acute stage, it's price. Remember, protect the tissue, rest the area, ice to reduce your swelling, compress and elevate above your heart. This is where people don't get it right. They'll just, oh, my foot's elevated. Yeah, but you're still in a seated position and it's not above your heart. We want it above the heart so the lymph and the blood is flowing away from that area. Get that inflammation out. Chronic pain conditions. So, a decrease in ischemia and trigger points in soft tissue. I'm trying to figure out what I'm doing here. Okay. This would be what happens when you have a chronic pain condition. Then we're going to restore flexibility with joint mobilization and passive or active stretching with the client. So trigger points to release the tension, range of motion. Then the body will rebuild strength. They can do it with their exercise program or weight training or physical therapy if that's what they're doing. And then after things start healing, they can restore the endurance and things are kind of more back to normal. So if someone has chronic pain conditions that they're seeking help for, it is ultimately up to the client to continue their self-care. They can't expect results from us if they're not doing anything to help and play a part for their homework. That made no sense. They need to do their homework. They can't just rely on us. Treatment manipulations. So you guys kind of already know these techniques. Neuromuscular therapy is actually really in depth, but it goes along with understanding how the nerves and the muscles work and trying to deactivate trigger points in taut areas. So it's a fancy therapeutic massage modality. So a lot of these treatment manipulations would include your superficial gliding. We already know that. That's that effleurage. Then you have your deep gliding or your muscle stripping. Then we have our trigger point release. So if you guys were to happen to find a spot on the body that feels like a little knot or just a tight area, you can apply pressure. Now, all kinds of books and online are going to tell you all different things. This one says apply pressure on the knot for 8 to 12 seconds. Let go, let it rest a little bit, and then you can go back in and do more compression to that knot. So you can work a trigger point by just doing that, or you can do work with a trigger point by compressing and stretching. That's the pin and stretch technique. Stretching after you work on a trigger point is the best way to keep it from coming back fiercely. It's also not going to just disappear, but you're going to work at it, and the idea is to at least get that trigger point to be deactivated so it's no longer shooting pain in a referral area. So when you do stretching with your clients, again, you can do it passively and completely let them lay there and go through the range of motions, or you can have them help. The active technique is when we're using something called muscle energy technique. So that is when the client is helping us so that we can deactivate a tense area by contracting it and getting it tired. Good stuff. And we'll go over some stuff today, hands-on. Trigger points. You're like, what is that? There's a lot of different kinds of trigger points. So a trigger point is defined by a hyper-irritable nodule associated with dysfunctional contractile tissue. So dysfunction in a muscle that contracts, okay? And this elicits pain when pressure is applied. So there are many types I listed here, and we have a whole semester on trigger points next semester. So that's fun. And their referral pain, which you guys will see, is usually easy to figure out. But anyhow, types. Your active myofascial trigger point. That is what everybody thinks of as a trigger point that refers pain. You push on it, and it's going to refer pain to another area. Have you guys felt any of that working on each other yet? Where maybe you push on the neck and it goes down the arm a little bit or anything like that? There's a lot of good trigger points you can find in your hands. So a lot of times I'll like push on like any of the thumb muscles in your thenar eminence. And sometimes you can push on those areas and I will feel it over here. Like it'll radiate in my hand and I'm pushing over here. So that would be referred pain that aches in a different area. You guys will find it eventually. Now we have something called a latent myofascial trigger point or latent trigger point. This is a trigger point that's hanging out, ready to become active. So you push on it and it doesn't send that pain signal to a new area. It's just hanging out, waiting for things to get worse so that it could cause more pain. It's a devil. Then we have something called a central trigger point. This could be active or latent. This is near the center of a muscle fiber. So we're talking like muscle belly. So you have your, well, I like using biceps. The fattest part of your muscle is considered the belly, not the ends where the tendons attach to the bones. So this would be a trigger point, either referring pain or not. You might just feel that nodule that's towards more of that chunkier area. It doesn't have to be dead center belly, but somewhere within that chunky area. So you have your central trigger point in the chunk. Then you have your attachment trigger point located at the attachment point. So this is closer to the tendons. So tendinous work hurts more because there's less cushion. All right, so primary or key trigger points are trigger points that when they're active, they can trigger something called a satellite trigger point. This is good stuff. So you have your main trigger point, and now all of a sudden you have a bunch of other trigger points. Those are your satellite trigger points. Just think of like all the satellites. Earth is the trigger point, and all the extra satellites waiting for us to ask for pictures of whatever. Okay. So these satellite trigger points form as a direct result of dysfunction from one of those primary or your key, bless you, trigger points. So active trigger point hurts. Latent trigger point doesn't hurt yet. Central hurts in the middle. Attachment hurts on the attachments. Primary, it's that main son of a you-know-what. You got the satellites around it that can become trigger points, and then you have trigger points in other locations. This could be located in the skin. It can be in scar tissue, ligaments, joint capsules, fascia. So it's not going to just target your muscles. Cool? Cool, Daddy-O. Palpation effect. A trigger point is palpated as a nodule or a taut band, typically of muscle tissue, that results in dysfunction. So a lot of this, either the dysfunction would be pain or loss of range of motion, something like that. So an active trigger point radiates pain to another area. Causes for a trigger point. There's a lot of causes, and we go over all the causes for different trigger points and different muscles next semester. It's fun. Causes could be acute or extended overload, so overdoing it. Trauma. Dysfunction in the joint. Maybe your joint is bone on bone or arthritic, something like that. And it's causing dysfunction with the muscles that are trying to, that are around it or passing through that joint. Not through it, but passing over that joint. Arthritis, visceral diseases. So an organ can also cause trigger points and referred pain. Emotional stress is a big one. A lot of cortisol getting released. Your body thinks it's in fight or flight. Cortisol is inflammation paradise. And the next thing you know, you're having dysfunction and tightness in the muscles. Tightness turns to a trigger point. So in this picture here, I have lovely, lovely supraspinatus. The X's show where this person's active trigger points would be. And also the X's show where common trigger points typically are. So a lot of people get trigger points in the shoulder area, right? So X marks the spot. Red is where you can feel pain radiate. So say a person comes in and they're having, pain on the outside of their arm, a little in their deltoid. It does not mean their deltoid is the problem. So see how this could kind of show you a new way to treat the person. When in doubt, just work the whole affected area and every muscle you think that moves this joint, and you should be in good hands. But also, wait, let's go back. Also, if you push on this area and the person's like, oh yeah, that's giving me the pain where it is, that's a good indication that that is the trigger point for that referred pain. Headaches are a big one that have referred pain. A lot of headaches are stemming from tension in the neck. Not all. Some are hormonal. Some are dehydration. But a lot of times if it's a tension headache and you hit a spot in the scalp or the neck, it'll send an intense pain exactly to where your headache is. Usually if it's a migraine, it's like a ice pick through your eyebrow or your eye. Good stuff. All right, there's a fun little thing called the trigger point end plate theory. What this is it means trigger points, this is how they start. Usually there's strain or overuse or trauma. It creates calcium to release at a nerve end plate. So calcium is released. Got it? Then you have these two little filaments called actin and myosin. Those guys are supposed to slide like this together nice and smoothly. All right? Well, what happens sometimes is that calcium buildup will form a ball or nodule where the filaments can no longer slide nicely, right? When they no longer slide nicely, the tissue kind of balls up around the area. All right, this balling up will restrict circulation and reduce something called ATP, which is needed to remove the calcium. So when those don't get removed, you now have a taut band trigger point. Knot, we'll call it. A knot would be like a latent trigger point that's not causing pain. All right. Once you have this knot, the local area becomes weakened. So those muscle fibers will become weakened. And at that weakened state, the actin and myosin slide together and form that knot over time. So stress, trauma, calcium release builds up, makes a knot because the calcium can no longer get pulled out from the ATP. So that's a fun little quick way to explain how a knot is formed. So when people ask you, what is a knot? Tell them it's a calcium buildup eventually from trauma. They don't know why it happens. Scientists are still trying to figure out why we get these knots, because sometimes it's not really caused from trauma, and it could just kind of form. And I would say that would probably be the body just in some kind of distress, is my guess.
I listened to that podcast last week.
Did you really? Overachiever.
She was talking about the nodules that we feel, and a lot of times that it comes from our daily activity.
Yeah,
So
that's why it's important to ask what people do,
so
their hobbies and whatever.
She was saying rather than trying to like rub it, get rid of it, like we need to learn to integrate it into the muscle and working through it and trying to soften it, that a lot of times our body has built it as a defense.
Yeah, it is. Our body builds things because there's some kind of dysfunction happening there. Kind of like bone spurs. A lot of times our body will build that extra bone because maybe that person's gait is off, or they walk different, or maybe they have arthritis, and maybe there's a lot of times it's plantar fasciitis or a tight Achilles muscle. Right, so that'll cause dysfunction in the bone and cause the foot to start creating more bone mass. So you get your bone spurs. But same with the knots. We're creating those knots because this is what our body is used to doing. And it's trying to restrict that movement so there's not further injury, but it causes more issues. So our body's great when it works correctly. But I always tell people, they're like, oh, did the knots go away? No, they are your forever friends. But what we are trying to do is to create less dysfunction and give you more range of motion, less pain, and manage it. It's not going to go away. So you can't just squeeze a knot and have it melt. I know I've told you guys, that's not real. It doesn't happen. But you can soften the tissue around it to kind of diminish it a bit. So here's pictures of palpating a knot in the muscle tissue. You have something called the flat palpation technique and pincers. Depending on the area of the body, most of it's going to be flat palpation. Most of us can't just pinch your skin unless it's an area where it's not as meaty and there's more elasticity in that region. So a flat palpation, again, is done with the tips of your finger. Typically, we're talking about the pads, not the very tip, because we don't want to push directly down and put stress on our joints. So try to keep it as neutral in a flat position as possible. And you can also do that with your thumb and palpate things. So typically, you are kind of going across the muscle to kind of feel. Pincer, on the other hand, would be literally trying to pinch it. So a good spot where you can do this is the trapezius muscle. A lot of times you can literally pinch that bad boy and try to find knots that way. But most people are going to do the flat palpation in most areas. Where does it say? So the pincer says, employed in areas where muscle tissue can be picked up in between the thumb and finger of the same hand, where the belly of the muscle is rolled between the thumb and the fingers. So, again, you're not going to do this in a very tight area of the body. Deactivation techniques that are not in our scope of practice. We are not allowed to do this. This would include, but not limited to, trigger point injections, dry needling, or acupuncture. We are not allowed to puncture the skin. We are not doctors or nurses or acupuncturists. All right, trigger point injections could be several different things. So a lot of times they're putting some kind of pain reliever in there, lidocaine, procaine, or just saline. I've also heard of sugar injections. Is it weird?
It's been a long time, but yeah, but I swear the next
Worked
day
great.
I felt so much better.
Yeah, so
my IT band was so inflamed I couldn't walk.
Dang, girl.
Yeah.
So the trigger point injection with sugar, or any injection with sugar, the reason why they're putting a sweet, sugary substance in you is because sugar is an inflammatory. So the reason behind this is to activate the histamines to clean up the area and heal it. So usually with that type of therapy, you get worse before you get better because you're letting the body do the healing. But we are not allowed to put needles in people. Also, estheticians aren't allowed to technically put needles in people either unless you have a medical license. So like the medical estheticians, they are allowed to poke the layers of the skin with things. That's why they can do the Botox where a normal person who does facials, normal esthetician can't. So also, if you're getting needles put in your body, make sure the person is within their scope of practice before you give them their money. Your money. You're not giving them their money. All right, trigger point deactivation that is within our scope would be vasocoolant spray. I have never used this stuff, but you spray it, it's real cold. You can do a stretch, and it's like an instant ice to the skin. Ischemic compression or trigger point pressure release. So that's just applying digits, 8 to 12 seconds. Some people say 15 seconds. I just hold it however I want. That's how I do it. Release, give them a break, and then go back. I do it about 3-4 times. Positional release. I don't do positional release, but we'll run over it a little bit quickly because I don't do it and I don't understand it. Fair enough. It's just hard to wrap your mind around. And muscle energy technique. This is highly used. It's awesome. MET is awesome. So trigger point release. See, again, we have another one down here. 8 to 12 seconds. Whoops. Anyhow, so trigger point pressure release, they call ischemic compression also. So myotherapy. What is that? This myotherapy is used to relieve pain in muscles by releasing trigger points using ischemic compression or corrective exercises. This was a popularized manual treatment for trigger points in the early 1980s, okay? I can't word. So trigger point release would involve, again, pressure applied with a thumb, a digit, or your elbow. Now, if you're doing trigger point release with your elbow, you're not going to feel it as well, right? You don't have as many, your elbow's not as sensitive as your fingers, right? Pressure is released. Hold on, I'm trying to read what I wrote. When pressure is released, fluid returns to area. So what we're doing is, you ever notice that when you apply pressure, the area kind of gets white for a second, and then you let go, and it gets red again, pink? So that's what we're doing. We're applying that pressure, limiting the fluid, we'll say, the circulation to that area, releasing it so that there is a surge of blood flow. When we're applying pressure, according to the St. John method of neuromuscular therapy, we hold it for 8 to 12 seconds. So that's why I'm like, I don't know, 10, 15 seconds, because everybody has a different answer for this. Probably. What would Bridget do? 12 is a good one. That's kind of between it all. All right. Neuromuscular therapy to release the trigger points. This is what the book said too. The book tells you so many things. You press and hold, now it says 3 to 12 seconds. What did I kick over? Oh, posters. I'll get those later. Press and hold 3 to 12 seconds, then release for 3 to 5. Then you can go back for more. Some trigger points respond better to taking longer breaks. So sometimes you can hold that trigger point and then go to a different area of the body, okay? Give them a little break, because too much in one area for too long is overly stimulating and can get irritating. And people are not going to want to go back to you if that's how you massage. So follow trigger point release with gliding or J strokes. So J strokes, you're doing a literal J. But who even pays attention to that? just let your hands move. All right, passive or active stretching may be used. I think stretching is great. Like I said already, do stretching after a trigger point release if you can. I know some areas are a little harder to stretch. You're like, how do you stretch your shoulder? Well, crossover. That's not an area you're going to be able to easily stretch on your client. Makes sense? But if you're doing trigger point work at a forearm, you can easily stretch the forearm or the neck or areas like that can, do the active or passive stretching. So your failure to return the muscle to its relaxed state may increase the chance of that trigger point reactivating. So stretch them, get them in a relaxed state. All right, that way the chances of that reactivating to cause pain or referred pain is lessened. So Jones and Chateau, I think I say that right. I don't know. Came up with positional release to inactive trigger points. So to find this position, we are passively moving the joint in the same direction that the involved muscle would be if it were contracted. So in our fun little brain, we're going to do biceps again. Okay. So we're getting it in the same, passively, we are moving it passively in the same direction of contraction. The preferred position is about mid-range, okay? So this is about mid-range, 90 degrees about, right? When the position is achieved, typically your trigger point pain and sensitivity will drop down 70 to 100%. So the idea is to get this muscle in mid-range to cancel out the activation. You would hold this position for a minute to a minute and a half. And then the joint, in this case, it could be the elbow or, the bicep does both. It also flexes. But in our case, we're talking about elbow. You would compress the joint 5 to 7 pounds and then slowly put that back into neutral. So mid-range, hold the position, compress the joint that it moves, and slowly drop it back down. That's what a positional release is. But like I said, I don't do positional releases at all. I do muscle energy technique, baby. So muscle energy technique has 2 basic inhibitory reflexes. So this inhibits the trigger point. You have your post-isometric and your reciprocal inhibition. Post-isometric follows an isometric contraction. So you guys haven't learned that yet, right? Okay, so isometric contraction, we'll say, is when 2 things are contracting at the same time. Like if you're holding this like this, like, I'm gonna like punch you, you're mad, right? So both sides are contracting at the same time. So hold on. Isometric. We have, where is it? Your concentric, your eccentric, there, I just remembered it, and your isometric. So when you have a concentric contraction, think of the word, I'm going to write it down. We are talking about the muscle that's contracting. So a concentric action is contracting the muscle. Bicep again. When the bicep is in eccentric, it is lengthening. So contract, E, that's just the opposite, all right? So bicep, contracting, right? And then as it's lengthening, this is actually the concentric now, the tricep. But as it's lengthening, we're getting into eccentric. Does that make sense? Concentric, eccentric. So the isometric is when both contract at the same time. All right, typically this would be, if you're doing a plank, for instance, a plank is a great isometric exercise. You notice how you're shaking when you're in the plank position on the ground, those suck. All right. You are using both your postural muscles, so your flexors and your extensors, to get that straight line plank. So that's a isometric contraction. You guys are going to learn about that more in detail, but that's basically it in a nutshell. Next semester. Probably with Alyssa. I don't know yet. All right, so post-isometric relaxation. Now you kind of know what that means. So after the isometric contraction, right? Okay, so following that contraction, there is a period of relaxation during which muscle impulses are inhibited. So you are tightening it to get it to relax. And I'm going to go over these later, okay, when we're working on each other. Reciprocal inhibition is when a muscle acting on a joint is contracted. The muscle responsible for the action opposite to that is then inhibited. So what that means, I have a good example here. When you contract your quadriceps, the opposite muscles are going to relax. They cannot contract at the same time unless you're in a isometric exercise, okay? So naturally, when one does one, the other does the opposite. So that is what your antagonist is. So your quads, all right, this is your synergist. This is the guy doing the work. Your hammies, that's going to be your quads antagonist. That is the opposite, kind of like biceps and triceps. We'll say this guy's moving, he's your synergist, and this guy back here is your antagonist that's causing the opposite motion. Also, the reason why we need that to happen is so that your joints don't just overstretch all the time. So you need those ligaments to be giving you some kind of tension or resistance so that you can move in the directions precisely. So that's fun. So what these two mean is the first one, you're contracting. The main one here is I'm going against, remember how I told you guys, say your client's pulling forward and I go against it? That is your post-isometric relaxation technique. Okay, so see how nobody's winning? All right, see how I'm shaking a little bit? That's an isometric contraction. We're doing that to relax the muscles. It's actually having both sides contract together. And then the opposite would be, again, to contract the opposite muscle. Say I want to relax the hamstrings because they're tighter than hell. Oops, I shouldn't say that online. They're tighter than sin. Woo! Sorry. You're going to contract the quads to relax the hamstrings. So that's a move that you guys can do. You can bend their knee into flexion when they're face down and then have them actually contract the quads.
So would you have them kick back into your hand then?
You can for the post-isometric.
Okay.
So these, you can just call them muscle energy techniques. But yes, kick back into the hands. A lot of times I will also, as I'm working on the hamstrings, put that knee into a flexion so that now I have those in a shortened state and I'm working on them.
Jamie, I did you good the other day.
Did you? Did you?
Because I was like, I know I can do this, but I don't know what I'm supposed to do.
You're like, I don't know why, but I know this is done.
When I was lifted your knee or bent your leg when you were.
Yeah, so you can work on a muscle in a relaxed state or a compressed state, or contracted state. All right, where am I at? All right, during the application of muscle energy techniques, the client contracts a muscle against the resistance of us. And then always tell them, don't let them win, and then I won't win. That's what I tell them. Sometimes I'm like, less, or more. Sometimes it's just like, no, it doesn't do it that fast. Woo, boy. Muscle energy application for hypertonic muscles. A hypertonic muscle is a muscle that too much tone, overly contracted, too tight. That is a hypertonic muscle. A hypotonic would be a muscle that doesn't have enough tone. It's weak. Does that make sense? I hope. Okay, so there's 3 variations of muscle energy techniques. You have your contract, relax. So this is basically what we were just talking about in the other one. And then your antagonist, contract. You can also combine the two. So that's funsies. And just see what works best for your client. So the contract, relax is another word for that past slide there. Incorporates post-isometric relaxation theory, right? Which states that as soon as an isometric muscle contraction releases, the muscles relax. So that is your most common form of muscle energy technique. So when you do muscle energy technique with this relax, contract, relax technique, you have to know what direction the muscle's moving and why you're doing this. This is why we're learning this stuff. A really good area to do this on, because this area is hard for a lot of new therapists to get into, is the neck. So you can, as your client is laying on the table, have them push their head into your hands. And what you're doing is any of those lateral flexors in your neck are going to be hanging out doing the contract, relax muscle energy technique. And then when you do that, you have a natural, it actually feels sore, like it's been worked out when you're pushing against it. So that is, the neck is a really good muscle energy technique area. And the legs are so good. It's all so good. All right, antagonist, contract. Again, this is when you contract the opposite muscle that you're trying to release. All right, so again, say you want to relax the hammies, you engage the quads. This is preferred method after a trigger point release. So if you find a knot and you do trigger point release, you can do the antagonist contract, okay? Or you can, like I said, combine the two. It doesn't matter which one you end on, but both are fun. I usually do number one. That is the go-to for me. I like that one. It's good. Good stuff. Myofascial release. So this is a picture of fascia. Isn't that great? So you have the layers of the skin, a bunch of fascia, and this to me looks like muscle because of, if I zoom, you can, oh God, go back, bro. You can see all the compartments, right? We'll pretend. I feel like it's a muscle fiber. Fascicles. All right, so fascia. We already kind of know this, but let's just let it sink in. This is connective tissue. It is composed of fibers and cells suspended in a matrix called ground substance. So you have ground substance, the goo, and then you have collagen and elastin fibers and reticular fibers. So collagen and elastin are strong and flexible. The reticular fibers are web-like and provide structural support. We need all of this for us to function properly. Fascia can be really, 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 really tough too. So you want it to be strong as steel, but also flexible. And it's funny because there's different types that can do all of that. And the reason why we need that is so that we can stand up straight or sit up straight or keep our head straight and not having it just flop to the side. So fascia is really important. There's two types. Your superficial, your looser fascia, and your deep, dense fascia. Now remember, fascia surrounds every part of your body. Every fiber, your organs. It separates your muscles into different groups for different functions. And when this gets, we'll call it sticky. It's not really sticky, but when this gets too hard, it can cause restrictions. So sometimes those collagen fibers are the death of us. And they're not letting that fascia move freely. And remember, heat will soften the tissue and cold will stiffen. So yes, they might have inflammation. You want them to hit that area with some ice or cryotherapy of some sort. But notice that sometimes it'll make them stiff and more pain. There might be more pain from prolonged ice. Myofascial release. So these techniques are used to stretch, broaden, and soften all that fascia, thus making the ground substance more fluid. So the more we work that hard clay, the softer it gets. I was going to say something here, but I forgot, and it's probably going to come back to me at a really dumb time, but let's go. So myofascia, or for fascia, we want to look for postural imbalances. So look how they walk, how they stand, so gait, maybe even how they run. Look for elevation in your hips, your ribs, shoulders, clavicle, head tilts. Anything that looks like it's not, asymmetrical. Make a mental note of that, and sometimes a note in your soap notes. A big one is check the length of the leg. Most humans don't actually anatomically have a shorter leg. Most of the time, if you notice one of their legs is shorter, it is a structural problem. Not structural, a musculoskeletal issue. So it is tissues doing that. It might be a hip that's out of alignment, and now it's causing all those muscles to pull that leg and that hip up to make it look like that leg is shorter. So I'm going to teach you guys, we're going to do more of this when we're doing the hips so you know what structures I'm talking about, but I'm going to really, really hound you guys on hip and shoulder heights and how to fix elevated issues. I can't wait till we do the pelvis. I actually worked with a physical therapist up in Berea, Ohio, who's awesome. And I learned a lot from her because she specialized in pelvic floor dysfunction. So I learned a lot of my pelvic work from working alongside her. She's awesome. Myofascial release techniques. So techniques, first assess tissues and palpation techniques. I remember what I was going to say now. A lot of myofascial release, you want there to not be a whole lot of glide. So it is easier with little to no lotion to do the superficial myofascial release. Now, you can start your massage and do your normal techniques, your kneading and effleurage, and as things, as the skin absorbs the oil more, then you can do some of your fascia work, but you can also start it with myofascial stuff before you do the lotion. But I like doing the lotion because then I can palpate areas. You can always wipe some off with a sheet or an extra towel. So some myofascial techniques would be your skin rolling. So a lot of times that's on the back before you lotion them up, and you can lift the skin and roll it. Tissue excursion. I have no clue what the heck that is and why it's on here, but it's from the book, man. Cross-handed stretch. This is what this person is doing in this picture. So you have one hand on mid-back range, one hand on sacrum, and you're pushing opposite directions. So what that's doing is causing a stretch in all that lumbar fascia. Then you have something called myofascial gliding. So typically that's just your putting your hand on the skin and slowly gliding. We're going to do a little myofascial stuff today because it's like my favorite. And that's probably why I go so slow as a massage therapist, because my massage techniques also have an element of myofascial release to it. And I think that that's what helps people the most, in my opinion. J strokes could be myofascial technique. Cross fiber friction is a say that 10 times, is a myofascial release technique in traction. So, so when you're pulling on the joints and creating that traction, you're also lightly stretching all that fascia within that whole range. And we'll do some techniques today where I pull on one of yours heads, whoever is my person that I'm working on today. And you'll see that just that light pull is going to move everything down to the toes. So that's weird to think, but yes, we are all connected in that sense. Our fascia is connected that far. So with that theory, if you have issues with your feet, it can affect things all the way to your neck. So that's why we're looking at the body as a whole when we're trying to assess the client and what to do with our treatment. And why sometimes you might have to get your upper body only client to let you do their lower body because it's so important. So a lot of times I'll tell my upper body lovers that don't want their legs on ever, can we just throw this in once in a while? Because it's so important to your overall wellness. Bottom little thing says all myofascial release holds and stretches should take at least 90 seconds. Now that's really long, so you can go in, release, and go in and do more. The reason why they say 90 seconds because it takes 90 seconds at least for your collagen to let go. So that's why we need the 90-second rule. So if you have an area that you're trying to stretch on your body that's causing you pain, set your timer for 90 seconds and repeat that about 2-3 times and see what happens. So you need that time frame for that to release. Craniosacral therapy. I've had this done, but I don't offer it because I don't have the touch. Some of you might be very skilled in this. So craniosacral, think head, sacrum, all right? It is a gentle hands-on method of evaluating and enhancing the functioning of the craniosacral therapy. So what that means is people who do craniosacral therapy believe that there is a connection, which there is, and I'm going to go over that too, between the cervical spine and your sacrum. We could see if he wants to. He is pretty shy, but we can see. We'll see. So craniosacral therapy was developed by a man named John Upledger. You guys have seen that name. Remember I misspelled it? Thank you very much. So with craniosacral therapy, typically you're working along the spine. A lot of cranium and a lot of sacral. Holds is what it usually is. This light touch is used to gently improve the flow of cerebral spinal fluid. So they believe, in this technique, it is believed that cerebral spinal fluid has a part in healing, which I think it does. So the craniosacral rhythm, they call it, can be transmitted through the fascia of the body. So if we can regulate this rhythm, it can kind of regulate, they say, the fascia a little bit better. So this craniosacral membrane barrier attaches to the bones of your skull, sacrum, and your tailbone. So that's the idea, is to work these areas to get cohesiveness with the craniosacral fluid. Deep tissue therapies. So here's a couple other therapies. So deep tissue refers to various massage styles that are directed towards the deeper layers of fascia and muscle. I just keep kicking these. Shameful. So remember, I'm going to keep shoving this down your throats. Deep tissue doesn't mean all the pressure you can summon. All right? It just means you are working more consciously at getting to those deeper levels. All right? More precision, not all the pressure you can summon. Typically, deep tissue is slower because it hurts if you go really fast. In this picture is something called structural integration, which a form of that is rolfing, which I also don't do, but I do in a sense. But anyhow, structural integration is bringing the physical structure of the body into alignment around that central axis. So we're trying to realign this human. So here's some cool pictures here. I'll go back to the pictures. Rolfing is a type of this that uses deep pressure to correct these issues, right? These issues are caused by incorrect body alignment. Usually there's a series of 10 sessions for this. So in this picture, we're doing deep work to fix his alignment issues. So in this picture first, these two pictures are before session 1, and then these are after. So you'll kind of see that he already got taller, right? In this picture here, he has a forward head tilt. He doesn't have much of a curve. He's kind of like straight in his pelvis. Let me see if the legs are any different. He has some bowed legs, man. But you'll notice even with the hands, this one didn't change too much, but you'll notice that this hand is slumped down towards the floor a little bit more. But yeah, he looks taller just because there was an opening in the chest here. So now we have a nice curve where this one, you can't really see much of a curve. So that's what is, you can even look in his butt. Not in his butt. We're not doing colonoscopies. Look at his booty right here, and you'll see how it's got a nice little, this is a weird conversation. It tucks differently where this, it looks like his, the pelvic tilt, this is what I'm looking for. It's different. So, yeah, this is a flat, like more of a flat back. So when his curve is restored, his height is restored. Kind of like if you think about like as you get older, you start shrinking. It's one, it's a posture thing, but two, it's also, you know, the discs in your spine are slowly deteriorating. So.
But it's weird in the after session 10, his shoulder, like his left shoulder looks like it's lower, but his right hand is still longer.
Yeah. It could just be him not having his fingers as straight over here, but
Maybe.
I mean, I'd say it's still elevated because even like if you look at his wrists, his shoulder looks back, actually. His shoulder is kind of back a little bit.
Looking at the side view, like his shoulder in that one looks lower.
Yeah, look. He needs more work.
But that's still a huge difference.
That's a big difference.
Yeah, I agree.
Yeah, and imagine how much better he's feeling because he's breathing better. And when you're breathing better, you're getting more oxygen throughout your body, and oxygen is like life. Let's see what his pulse ox is before and after. All right, there we go. Done with that.